Hi, everybody. Welcome to Silver Hill Hospital Grand Rounds. Thanks for joining us. We'll get started in just a moment as people settle in. All right. Welcome, everybody, to the Grand Rounds program at Silver Hill Hospital. I'm Dr. Jeff Katzman. I'm the Director of Education here, and we are absolutely delighted to have you join us today. We welcome Dr. Andrew Tatarsky, who will be presenting to us on the integrative harm reduction psychotherapy, a new treatment paradigm for treating addiction. For today's lecture, your questions remain an important part of our grand rounds, and I will moderate a Q&A discussion with Dr. Tatarsky at the end of the lecture with Dr. Gerber. This is a great opportunity to put forward questions and comments to our speaker, which you can submit anytime during the lecture by using the Q&A box. If you wish to receive CME or CEU credits, please complete the evaluation survey that will automatically show in your browser when we end the webinar today. Finally, disclosures: no planners of this activity have indicated a relevant financial relationship with an ACCME defined ineligible company whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. So let me tell you, it is my great pleasure and honor to welcome Dr. Tatarsky. Let me tell you a bit about him, and then I'll turn to Dr. Gerber, who will also add some introductory remarks. Dr. Tatarsky has worked with people who struggle with drugs and their families for over 40 years. He has developed integrative harm reduction psychotherapy, IHRP, for treating the spectrum of risky and addictive behavior. IHRP brings relational psychoanalysis, CBT, and mindfulness together in a harm reduction frame. IHRP meets people where they are on their positive change journeys and works collaboratively to support people in discovering their truth and what goals and approach to positive change best suit them. The therapy has been described in his book, Harm Reduction Psychotherapy, a New Treatment for Drug and Alcohol Problems, and a series of papers. The book has been translated into Polish, Spanish, and Russian. Dr. Tatarsky holds a doctorate in clinical psychology from the City University of New York and is a graduate of New York University's postdoctoral program in psychoanalysis and psychotherapy. He's a member of the medical and clinical advisory panels of the New York State Office of Addiction Services and Support. Andrew has trained individuals and organizations in 20 countries. His writing, teaching, clinical work, and leadership aim to promote a rehumanized view of problematic substance use and a harm reduction continuum of care that will extend help to everyone who needs and wants it, wherever they are, to begin their positive change journeys. And Dr. Tatarsky, I just want to say personally, I'm honored to get to spend this time with you and have really enjoyed getting to know you over the last weeks leading up to this. So thank you so much for joining us today. And I'm going to turn to Dr. Gerber, who's going to add some introductory remarks.
So I'll be very brief because I want us to get to the main event, but I did want to say that there's two very special reasons I asked Jeff if I could join today. One is that I've just found Andrew's work really quite inspiring because to me it brings to the addiction world a set of principles around customizing treatment for patients that I think is something that has taken too long as a field for us to get there in lots of areas, but is really increasingly happening across the board. And to me is a core principle of the work we do here at Silver Hill. So to get to know Andrew, to get to read his work, and by the way, I did not plan this, but I literally have his book next to where I sit because I find it so valuable. It's really an exciting idea to bring that same ethos of integrative work to the treatment of addictions. And then the last thing I'll say is a bit of a teaser, and I apologize for that, but as many of you know, Silver Hill has been in the process of collaborating with the Freedom Institute in New York and creating a partnership with them, still in the works because these things, from regulatory reasons, take a while. But as part of that, we are hoping to bring that collaboration to involve Dr. Tatarsky as well. And hopefully we will have something to say about that very soon. But I wanted everybody to know that it's going to be, I think, a pretty extraordinary collaboration between Dr. Tatarsky and his work, the Freedom Institute, and Silver Hill coming in early 2024. So on that note, I'm going to turn it over to Andrew T. and look forward to a great talk. Thank you.
Hey, thank you so much, Andrew G. Gerber, Jeff Katzman, Jane Cullen, for inviting me to present my work to your community, which might, in short order, be our community. And this is an amazing community to, as I've been getting to know more and more of the staff, the clinicians involved at every level. You know, and there are also some folks, colleagues and friends of mine from outside of the community, so I want to say hello. So, you know, I've been, as you heard, I've been working in the field for quite a while, and early on in my career, when I first began working in the addictions field, I learned the abstinence-only disease model approach to treatment, which was the only one that we could use at the time. And I think we helped a lot of people, but I became increasingly concerned about the fact that we are not helping back then and to this day, the overwhelming majority of people that struggle with substance use issues. And I've come to believe that it's really these dominant old traditional ideas about addiction and how to treat it that are at least limiting, in some cases wrong, and in some cases really dangerous and problematic. And so I've really come to believe that we need to completely shift the paradigm. But in fact, we are in the midst of a paradigm shift. So this is the good news, moving away from an old limited disease model of addiction to a newer version that I call psychobiosocial. That is, to think about addictive relationships, addictive process as really a multiply determined you know, a problem that, you know, that shift in thinking also supports a shift away from the abstinence-only approach toward an integrative harm reduction approach. And I, you know, am going to be giving a small taste of a body of work that I've developed and I offer in intensive trainings just to whet your appetite today. And I also want to say that I think that this approach can really enhance the effectiveness of care across the entire continuum, including in abstinence-based treatment. And so right at the outset, I want to disarm a common misunderstanding. And that is, many people think that harm reduction is really juxtaposed against abstinence-based treatment. And I really believe that if, in a very simple way, we think about a harm reduction approach as really tailoring what we offer to people to where they are on the whole spectrum of readiness to change, severity, etc. For some people, abstinence-based treatment is really the best choice. And so I really see that as falling under the harm reduction umbrella. Next slide. The next slide says that I have no financial disclosures to make. And next, please. So these are 3 educational objectives, but you'll see in a minute in my next slide, I have a number of more things that I want to get across. But I want us to be thinking about, you know, what are the realities that people who struggle with problematic substance use kind of bring into clinical settings. I want to, and you'll hear me throughout, discussing the limitations of a traditional abstinence-only treatment. It would be great if, when we're done, you could recite 5 basic principles that I see as defining a harm reduction frame. Next, please. So this is my plan. I want to say a few more words about my journey. Then I'm going to talk a bit about the paradigm shift. I want to then define harm reduction and the core principles. We'll talk about some of those realities that people that struggle with substance use live with. Then I want to shift to this new paradigm that I think of addiction as a meaningful relationship, multiply determined, meaningful relationship that's informed by psychology, biology, and social contexts that are all interacting in a kind of dynamic way. Then I'll introduce kind of an overview of integrative harm reduction psychotherapy, and we'll talk about a few therapeutic considerations and techniques that you can take away. Next slide. So as I said, I began seeing a bunch of patients in graduate school who were struggling with substance use. And I thought that this was such a interesting, diverse and lovely group of people that were really underserved. And I had such good early experiences that I decided to specialize in the field of addiction. I got my first job at a multi-modality addiction treatment program and learned that disease model abstinence-only approach. And over the course of the first 8 years or so of my career, I worked in that model, and I think we helped a lot of folks, but I began to see that actually the majority of people that were coming to the programs I was working with were not completing treatment successfully. In some cases, they just disappeared. In others, we had to terminate them for continued drug use, which began to deeply concern me. Why were we kicking people out of treatment for using drugs that were in treatment for using drugs? And as I looked around the field, I noticed that this seemed to be kind of the standard in the field, that most people were not completing. Many people who did complete were not maintaining their gains. And I began to wonder whether the disease concept, the old limited disease concept, and the abstinence-only expectations were really fundamental stumbling blocks and barriers to treatment. To this day, the data on traditional or mainstream addiction treatment is still pretty much the same. Most people don't go, most people don't complete, or the majority don't, and many people don't maintain their gains. So in the early 90s, I started a small private practice, and I began to get referrals of actively using people that were really struggling with drugs, but were not interested in stopping or not ready to stop. And many of them did incredibly well, reducing their substance use, in some cases stopping, working on other complex issues. And so now I was in this quandary. The mainstream approach was not helping the majority of people. Breaking the rules was. And I happened to have the good fortune to know a man named Dr. Alan Marlatt, who was an addiction researcher and clinician, one of the mental health professionals that brought harm reduction over to the US from Europe. And I called Alan and I shared with him my quandary. And he said, Andrew, you're doing harm reduction. In 1994, that introduction to this new alternative way of working with people really set me on a journey. I really saw it as an alternative frame, as I put it, for setting up effective helping relationships that could really expand our reach to this large number of people that we have not been effectively helping. And so I've been on this journey of really drawing out the therapeutic helping implications of the harm reduction model. And that's what that's what evolved into integrative harm reduction psychotherapy. Next, please. So what is this new paradigm that's emerging? I think of it as a solution to the problems or the limitations of our effectiveness at helping. I think of this new way of understanding problematic use as a rehumanized view of problematic substance use and other high-risk behaviors as multiply meaningful. Trauma is often, if not usually, at the heart. And in the addictive process over time, meaning and habit become embedded in neural networks. So to say that addiction is not a disease is not to say that it is not deeply ingrained and very difficult to change. And also that obviously it can have catastrophic consequences for individuals, families, and communities. I think what we're learning, in addition, is in contrast to the old view, which was more of a one-size-fits-all view, one unitary way to think about addiction, one unitary approach to treatment. We now are learning that there is no one way to treat trauma or addiction. We hear people talking about multiple pathways, or as a student of mine once suggested, if it's really about unique individuals in unique life circumstances, might there not be infinite pathways, to recovery? And I'm going to suggest that a harm reduction frame is really an essential corrective to a lot of the dominant narratives about addiction as disease, about addicted people as morally weak or selfish, or all of these kind of stigmatizing views or assumptions that are kind of embedded in our culture. Next, please. So what is harm reduction? Harm reduction, and I will break this down a lot more, but is an alternative way of thinking about reducing the harms associated with risky behavior, risky substance use, without necessarily requiring abstinence or even addressing a change in the substance use itself or the behavior itself. Although, of course, abstinence or a change in the behavior can also be harm reduction. It really emerged in the 80s in the midst of the HIV/AIDS crisis, when saving lives, communities began to realize that saving lives should take precedence over requiring people to stop using drugs. And that's really how it took root as a public health and kind of activist approach. And as you'll see, then Alan Marlatt was one of the key people that introduced several clinicians, therapists to the harm reduction model. And so harm reduction treatment or harm reduction therapy is kind of a subdivision within the harm reduction movement. Next, please. So in 1996, the National Harm Reduction Coalition here suggested that harm reduction is a set of ideas and strategies. I think that most people know of harm reduction through its public health strategies. It's a four-part movement, however. The first pillar, in a way, is grassroots, joining with public health to save lives and prevent illness. Obviously, if we can't help people stay alive and healthy, we can't help them do anything else. The second pillar is human rights. I think arguably the war on people who use drugs may be the greatest harm associated with drugs. And so that's another wing. Housing First is applying harm reduction principles to housing, supportive housing, based on the notion that people really have a right to a roof over their heads that's not contingent on their substance use status. And one thing we find with Housing First is that when we give people a safe place to live, substance use tends to go down and mental health tends to improve without any other interventions. And then the pillar that we'll be talking more about is treatment, applying harm reduction principles to helping relationships. And one way to think about it very simply is with this phrase, any positive change, as opposed to the old abstinence only view, that is abstinence as the only acceptable goal, measure of success, and often, a requirement to commit to abstinence to get into treatment. Next, please. So these are the principles, as I understand them, that I think about as a therapeutic frame. The first one, Alan Marlatt suggested, is compassionate pragmatism as the philosophy that gets expressed in harm reduction practice. I find myself often thinking and asking clients, patients, how's it working? But compassion is what what drives our desire to reduce suffering. The pragmatic part is really the heart of a harm reduction approach, which is that we need to be constantly evaluating what we're doing, our principles, our practices, what we're doing in a given moment with a patient in terms of how well it's working. And we need to be willing to constantly evaluate and shift gears if it's not working. And that's really a pragmatic, not an ideological approach. Any positive change, as I said, is, I think, kind of the major shift away from abstinence only, but to any reduction in harm without requiring abstinence or without imposing our agendas and values on the people that we're trying to be helpful to. And I think what's so beautiful about that is it really asks us to check ourselves. And I'll say more about this as I go forward, but our own countertransference, our own judgments, et cetera, so that we can actually create a safe space for a person and support them in exploring and discovering their truth and what approach to change makes sense for them. Then we can truly meet people where they are around whatever their goals are: safer use, reduced use, moderation, and abstinence, or whatever the person wants to address. And that's really so key, because somebody may be, using in a very problematic way, but not be motivated to address that issue or bring it into treatment, but is interested in working on other issues, right? So this really enables us to kind of try to discover what that particular person is motivated to work on, and then we can join them there, and that becomes the point of contact around which we can establish our alliances and therapeutic relationships. We can tailor services, and non-judgment and empathy obviously are critical. I think another fourth major shift and principle is the idea of small, incremental, gradual change, either in the behavior itself that is, problematic, or in all of the issues or any of the issues that may be kind of, related to that behavior, that may need to be addressed before we can even get to addressing or helping that person address this problematic behavior. And finally, guided by principles of curiosity, empathy, respect, empowerment, and collaboration, I think, are really kind of the key shifts. I think of the older approach as really being a kind of authoritarian, prescriptive approach. I know what your disease of addiction is. I know what you need to do about it. We have this wonderful program that you can just kind of step right into. This approach really says, you're a unique individual. We have to work together to figure out and help you figure out kind of what your goals are and what's going to work for you. And then we can support people on their positive change journey. Next slide, please. So I want to say a little bit about Peter and Sarah. These are two people that I have written about. I wrote a paper in the Psychotherapy Networker, which kind of expands a bit on this. And I'm actually will be sending a bunch of papers to Jane, who's in charge of this, and she'll be sending them out to people who request them afterwards. Peter was a man who was a professional who came to me about 6 years ago, and he reported to me in the first session that he was smoking crystal meth and was going on these multiple day binges with multiple partner sex. Some of the partners were anonymous. And he said that he was having a love affair with crystal meth, in spite of the fact that he was acutely aware that he was putting his life in great danger, his profession in great danger, but he was kind of caught in this dilemma, right? And he told me the only reason he reached out to me is because he knew that as a harm reduction therapist, I wasn't going to require that he stop using. So I deemed him to be a good candidate for therapy. He was motivated, he was suffering, he wanted help, he wanted to engage in a meaningful way, and he did. And what became clear is that, right on the other side of this love affair with crystal meth was, this intense, complicated grieving grieving his father's death. And there was a whole complicated backstory that, the love affair was pushing down, pushing away. Sarah was a 30-something-year-old woman who also came to me because she was engaging in alcohol use and pot smoking that at times would leave her with a hangover the next day. And and occasionally those hangovers could create a major medical crisis, which could be lethal. She sort of also presented this kind of picture of really enjoying the substance use. It was, how she had fun. It was how she relaxed. And yet she said that she was acutely aware that it could kill her. And yet she was caught in her version of this dilemma, right? She had a medical doctor that had been working with her for 7 years, who was sort of trying to get her to stop using and go to AA. And finally, after 7 years, he referred her to the harm reduction therapist. During those 7 years, there were many, many instances where she really hurt herself and came close to dying. So I mentioned both of these people because I think that while they have their own unique stories, I think that the overwhelming majority of people that are struggling with problematic substance use have some version of a dilemma like this. On the one hand, the substance is serving some important function, and on the other hand, people are really suffering, right? But they're caught. In Sarah's case, as we began to explore into her desire to use substances, it was almost as if Pandora's box, blew open, and she was flooded by memories of trauma and intense, suffering and pain and grief and suicidal ideation. So this substance use was also serving a function that, to keep these feelings at bay until she was in a therapeutic context in which she could begin to feel safe and begin to kind of explore and open. Just cutting to the chase, both of these people did incredibly well in therapy and are both now doing incredibly well in their lives. So my question is, how many psychotherapists who have had very little training in working with these kinds of issues would accept patients like this into treatment? And how many addiction treatment programs would accept them into treatment? And I would guess that the overwhelming majority in both of those groups would not. And that's where I think kind of a harm reduction approach is necessary. Next slide, please. So at the point that people become concerned about their substance use, I like to ask large groups of people this question, what percentage of those people do you think are ready to commit to stopping, commit to abstinence? I imagine that everyone in this group would agree that it is a relatively small number of percentage of this group of people. So I think most people don't want to stop, or they may want to stop, but not be ready to commit to that. Also, I think that most of these folks, like the two patients that I just mentioned, are in pre-action stages of change. That is, they're concerned, they want to feel better, they want some help, but they're not really ready to, move into action. There's a lot of work that needs to go on for many of these folks before they can begin taking positive action around change. Another, I think, core reality is that many people have different goals for different substances or different behaviors. They may be very interested in stopping one that they identify as problematic, but not others. And a lot of traditional addiction treatment has really had a total abstinence requirement. And I think that that's been a major barrier for people to getting into care. And finally, abstinence is not realistic for most, quote, addictive behaviors, eating, shopping, sexuality, et cetera, et cetera. So one thing I think it's important to consider is, why do we basically take a harm reduction approach when we're working with these other behavioral problems? But we tend to presume that people who are in trouble with substances need to stop. Just something I want to throw out there for folks to think about. Next, please. So this is the stage of change model that I think is really helpful for us helpers, for the individuals that are struggling, and for their concerned significant others. Prochaska, Norcross, and DiClemente did a massive study of positive self-changers, that is, people who were struggling with problematic behavior and made positive change on their own. And through a series of interviews with this group of people, they came up with this model. Basically, they found that people tended to need to go through these stages or steps before they could get to that action stage. On the bottom is pre-contemplation, and pre-contemplation refers to people who don't experience their behaviors as problematic. And it could be that it's not problematic to them. It's problematic to somebody else, possibly. But it might also be that people haven't yet connected the dots, that they may be suffering using substances, but haven't yet made the connection. And so at this stage, I think a lot of people have been kept out of traditional treatment. A harm reduction approach would see this as engaging people around assessment. Why are the concerned significant others concerned and they're not, right? And so it may be that the focus is really what a person would be motivated to work on the relational issues, and then that could kind of lead to a consideration or a clarification of what's going on with substances. Then people who are concerned about their use, like Peter and Sarah, would move into a contemplation phase where there's a lot to contemplate. Why do I love this, even while it's putting so much at risk, right? What's driving that? What's inside of that? Why am I reluctant to think about change? Fear. I mean, there's so many complicated dynamic issues that may need to be sorted out, before people are kind of clear about a positive change goal. Even then, so let's say the substance in Peter's case was kind of supporting a dissociation of this complicated grief reaction. He needed to have a place to begin to explore that. And then as he felt like he could begin to make some headway with the grief in therapy, that was sort of an alternative goal. Then he was more motivated to cut back and ultimately stop, the crystal meth use. But so, when people have a clear sense of a goal now, there still may be a lot of work to be done to kind of prepare to work toward that goal. Do I need therapy, inpatient, outpatient? Do I need detox? Do I need to involve my family? Do I, need self-help support? Can I do it on my own just by kind of changing, the structure of my life? So when people have kind of gotten clear about their motivation, their goal, they have a strategy, then people can move into action. So the point of this is that there's a lot of work that needs to be done generally before people can take action. And in those pre-action stages of change, folks need to be engaged. And that's another, I think, real benefit of a harm reduction approach that meets people wherever they are in that model. Next, please. This slide is really about kind of a shift in the way that we're looking at problematic substance use, really as on a continuum rather than that old binary disease model. We know that people move up and down the continuum. We are now embracing substance use disorder as mild, moderate, severe. But the old disease model said that, once you have this addictive relationship to substances, you can't turn back. And what research is telling us is that many people do moderate or stop without treatment. And people who have been really down in the severe end of things, can in some cases achieve stable moderation. Of course, there are many people who can't. And, so the harm reduction approach is not about promising moderation. It's really about creating a space in which to support people in clarifying what goals or what relationship to substances is most realistic and healthy as they define that. And so clearly, people can come out of this with a commitment to abstinence or safer use or moderation. Next, please. So the net of all of this is we need to engage people in all stages of change around non-abstinence goals. And that's exactly what a harm reduction framework is open to. I wrote a paper in 2003 called Harm Reduction Psychotherapy, Extending the Reach of Traditional Treatment. So let's consider that abstinence-based treatment may be wonderful and life-saving for some percentage of folks. This harm reduction frame then is going to help us or enable us to extend the reach to that large group of people that we have not been successful at engaging. Next, please. So what do we gain if we shift to this kind of lens of a meaningful relationship to substances, or a dilemma, as I've put it? Next, please. Well, let's consider that, we take a drug or we put a bet on the casino table. There's a biological reaction, of course. And that may vary from person to person, depending upon constitution and so on and so forth. But I believe that that biological reaction gets wrapped in meaning. That is, it means different things to different people. Some people really love opioids. Some people hate them. It may be partly, their biology. I think it's also largely the meaning. So in relation to anxiety, alcohol means that I can comfort myself, just for example. And I would suggest that it's important to think about these high-risk behaviors as often expressing multiple meanings on multiple levels, which I'll say a bit more about in a minute. And meanings are on a spectrum of awareness. And some people can tell you when I'm really lonely, when I'm really bored, when I'm really anxious, or when I really want to connect with people, whatever the it is, then I, find myself wanting to use a substance. Others are really mystified. The urge just seems to come out of nowhere. It seems to take over, and people are now, out of control. And I think, the old disease model would say that that's the evidence for the disease. And I think the risk is that then it would support a kind of, stopping the curiosity about what might be going on inside of that urge. It's kind of how I think about it, right? And now I think it's valuable to be thinking about the possibility of trauma and dissociation, right? And I think that this is a very important thing. I'll say a few more words about that, when we think about and consider there may be lots of meaning, that is parts of the self, painful experiences, et cetera, that are kind of living in that urge to engage in these behaviors. And from this point of view, we might consider that problematic behavior may be like a language that people speak. That is, that something's getting communicated that people may not be able to formulate in language, even, right? We have concepts like the unthought known, unformulated experience, or dissociated experience, right? That may get expressed in action rather than in words. Next, please. So this is kind of a smattering of potential meanings that the substance may have for people. And I think that there are many, many more. We could spend a long time exploring all of this. But I think problematic drug use is a response to suffering of one sort or another. People come to drugs and alcohol out of curiosity, a wish for fun, pleasure, connection. I think some people discover that these substances or experiences can self-medicate suffering. Ed Kansian, who was, a giant in the addictive behaviors field and a psychoanalyst from Harvard, gave us this concept of self-medication, which is now, really, very much in our culture. But I think that is really an important turning point in the paradigm shift away from disease toward thinking about a meaningful relationship. Now, it might also be substances may be a way of managing impulsivity or may reflect impulsivity of various kinds. I think trauma, as I said, I'm not ready to say it's always at the heart of addiction, like some folks are, but I think that it is often, if not usually, at the heart of addiction. And it might be developmental trauma, attachment trauma, that contributes to difficulties in attachment relationships later on. It might be big T trauma, or the trauma of being a person who uses drugs, who has experienced punishment, being terminated from treatment or a job, being kicked out of their family at the advice of a well-meaning counselor. And trauma, as we know, can contribute to real difficulties with self and emotion regulation. Trauma survivors tend to be, have very little windows of tolerance and can be very vulnerable to being triggered into hyperarousal, hypoarousal, two very painful states that both of which people can turn to substances to try to comfort or soothe or manage in some way. Then the shame and guilt of being a trauma survivor can be, intensely painful, contributing to all sorts of interpersonal difficulties and, psychic suffering. And obviously substances can kind of comfort a lot of those symptoms. Intense conflicts or splits within the self, the part that wants to connect with others at any cost, and the part that needs to be comforted, but has learned through developmental experiences, to keep needs and feelings private. That's one way to think about, Lisa Director writes about the relational meaning that gets expressed in the use of a drug. I think in a very simplistic way of turning, given early developmental difficulties or attachment difficulties, people are left with a feeling that they can't rely on others. They need to comfort and rely on themselves and may turn to a substance or other non-human activity to comfort, right? So there's both the, sort of the one person function of the substance to care for oneself and the relational meaning that gets expressed in turning to that substance. And others find that substances can help with bonding or intimacy or closeness. I think that was a big part of Peter's relationship to crystal meth. He could really feel very close to people in a way that he really wasn't able to, given a lot of his early developmental trauma. Next, please. So given this way of thinking, we might think about an addictive relationship as one that expresses and may disguise, split off parts, dissociated parts of the self. And from this point of view, the risky behavior and the urges to engage in that behavior may be entry points for exploration, rediscovery, integration of aspects of the self. So obviously, if that's true, we need to invite people into our offices while they're engaging in these behaviors. And in fact, I think that if we make a requirement to get help based on, stopping the behavior, when that behavior has been vitally important to a person's psychic survival, that may be experienced by people as a death threat almost, but certainly an impossibility for many, if not most people. So we want to be thinking about, like, what part of you wants this? Is there a part of you that you can connect with if that urge could speak? I call this unwrapping the urge, which I'm going to say a bit more about. Next, please. Now, to the extent that, we turn to an activity or a substance and it actually helps us feel better over time, we can inadvertently create what learning people call overlearned habits, deeply ingrained habits. We condition ourselves the way we condition our dogs, right? The stimulus is anxiety. The response is to have a drink. I feel better. And if I repeat that 1,000 times, what I've conditioned is not just turning to the activity, but the urge to turn to the activity. That hallmark of what we call addiction. So it occurred to me one day that the urge is the axis of change. Just imagine that, we can catch a behavior at the stage of the urge, stop the action, put a little pause around it. There's a technique, Alan Marlatt, called urge surfing, bringing mindful awareness and breath to the urge. Now all sorts of different possibilities become available to a positive change process. Next, please. And finally, as I say, when I say that I don't think of addiction as a disease, it doesn't mean that there aren't lots of biological factors. We certainly know that people with family backgrounds, problematic substance use or addiction are more vulnerable. In some way, there is some impact on how people experience substances, but also the neurochemical depletions, neuron receptor up and down regulations. These things happen over time with chronic substance use. So that I think that when somebody is really using substances chronically over time, the biological factors become more and more relevant over time, right? So the meaning, the habit, and then biology all kind of interact in ways as multiple motives for continued use of these substances. Yeah, next, please. So this is kind of how I put all of that together in the psychobiosocial model. That's not my term. Some others came up with it to really emphasize that the psyche is how we really intervene with people, right? We're working, when we're working with people, we're working with subjective experience that we then infer has some biological correlates, or do, but the connection there is, we're not working directly with people's brains. But so consider in the upper left circle, all of those things are correlated with addiction or problematic substance use. None of them cause it. So there's some set of factors that interact in ways that give rise to somebody turning to a substance and finding it really helpful, pleasurable, right? This works for me. I like it. It helps me cope. It helps me feel better, etc. There's some unique fit there. And that's what we want to help people, make sense of. Then if it's working in some way, and people are using over time, then there is this accumulation, maybe this accumulation of negative consequences, those brain changes, cognitive changes, etc. But also using in a society that criminalizes and stigmatizes people who struggle with drugs also contributes additional suffering, shame, guilt, anxiety, need to kind of disconnect. The disease model said that lying and hiding is really a hallmark of the disease of addiction. I think this model would suggest that it's much more complex and dynamically meaningful. Now, if there are negative consequences and people are going to feel worse, if where they turn, they turn to substances when they feel bad, it's likely that they'll increase their substance use. And I think that what we gain from this model is a couple of important things. Next slide, please. That it helps to explain that addictive dilemma. People are really getting something, or they have gotten some benefit, which is what motivates the part of them that wants to continue using, even while there's this accumulation of risk and negative consequences. It seems to me then that any positive change in any of the relevant factors is going to change one's motivation and relationship to the drug. So with Peter and Sarah, as they began to get some relief in therapy from, this complicated grief in Peter's case, and this history of trauma in Sarah's case, they began to feel more hopeful, feel like they no longer wanted to turn to the substance for the benefit that they were getting. And they then began to feel that the substances were really a threat in a way that they hadn't before. So the issues that one is motivated to address become these points of contact to develop the initial alliance around. Next, please. So these are the three first American harm reduction texts. Mine on the left is a book of psychotherapy stories, one of my own, 9 from other therapists. And then I really wrapped these stories in commentary and introductory, topics, really, to really bring people into, what actually goes on in the room when a person is sitting with a harm reduction therapist. Pat Denning and Jeannie Little's book is a great textbook. It really covers the ground in a very systematic way. And Alan Marlat's book on the right is a wonderful collection of research, evidence-based, kind of contributions to the harm reduction field. There are a few newer books that are out as well. So I would really suggest people, dig around, and there's a lot that could help you get really educated. Next, please. So now I'm going to shift to my approach. And the reason I call my approach integrative harm reduction psychotherapy is really to emphasize that I think that we need to be working on multiple fronts with people. If there are multiple factors that are contributing to people's problematic relationships to substances, I think the best treatment is a treatment that's going to be able to identify and address these multiple factors, right? And I think that that's been a real shortcoming in our field, where we've got psychoanalysts, working on clarifying meaning, and cognitive behaviorists working on, positive behavior change. It seems to me that we need a focus on clarifying the personal, relational, and social meanings and functions that these behaviors have. But we also need to have active cognitive behavioral strategies to support people in positive behavior change, assessing in what ways the behaviors are problematic, right? Developing skills of mindfulness is, I think, right underneath that. I think a core cognitive capacity that supports both of these other focuses, really. My training in mindfulness was with a guy named Ronald Siegel, psychologist from Harvard, and he basically boiled it down to a very simple idea, which I love: awareness with acceptance. I think we could also add curiosity there, kindness, openness, but this is really about cultivating that capacity to be aware in the present moment without judgment, just noticing what's present, what's here now. And that, of course, can help us as clinicians monitoring our own internal experience, our own countertransference. It can help our clients kind of develop these capacities to observe themselves, observe their behaviors, kind of dig more deeply into the meaning and the function that these behaviors have. And so all of these three components live within that harm reduction frame that I talked about before. Now, I also think about the integrative aspect is that, you can come at this work from whatever your particular background is and kind of integrate, different techniques and different strategies from all sorts of therapeutic approaches, but in a way that is continually negotiated with each patient, each client, so that we're working together to figure out, what is the useful focus for this individual in this moment, in this session, right? And this can shift, obviously, from minute to minute and session to session. Next, please. So this is the 7 therapeutic tasks that I think of as kind of, what is it that I'm trying to do? What are the main things I'm trying to do when I'm working with a patient? And none of these are new to you. I think what is new in this approach is that, we need to be thinking about what are the particular challenges that people that are struggling with active problematic substance use, who are likely to have experienced trauma and likely to have experienced negative experiences at the hands of helping professionals. What are they likely to bring in to our relationship in our office, around managing a therapeutic alliance, right? There's going to be major challenges for many people to establishing safety, establishing alliance, establishing trust. And for some people, that can take a long time, right? So we need to be mindful about how we need to adapt, our attempts to establish alliance with folks. Then, I think that the harm reduction frame really facilitates that, because it reminds us to really start where that person is, find their motivation, see where are they in terms of their ability to engage meaningfully. And how do we meet them there in a way to create safety? Then around that alliance, a therapeutic relationship builds, which itself, I think, is healing. Now, we all know about that around, the corrective emotional experience, the new relational experience, as we invite patients into our therapies, with compassion, empathy, respect, and so on. It can really provide a kind of a counter to challenge, kind of negative expectations about relationship and feelings about self, right? That can begin a healing process. I think that specifically a harm reduction frame that invites people to come into our offices with their active substance use and other problematic behaviors sends a message, often from the first phone call or the first encounter, that that is at odds with messages that people have gotten about themselves as people who struggle with drugs. And I think that that can both help create safety, but it also can support the process of exploring into the multiple meanings or the function or the aspects of self. As we invite them to share those with us, that can then facilitate that corrective emotional experience or new relational experience. The third task of enhancing self-management skills, I think, is so key, because to the extent that these behaviors are reflect difficulties with self-regulation, emotion regulation, as a way to kind of contain intense affect, intense feelings, to ask somebody to give up the behavior before they've really developed a capacity to sit still with distress, again, can be a real setup for failure. So in this third task, what we're doing implicitly in our empathic relationship with people, but also very explicitly with teaching self-regulation skills, mindfulness, breathing techniques, positive self-talk, grounding techniques, etc., I think can really help people kind of gain some greater sense of comfort with distress, capacity to tolerate it, right? And now it becomes possible to move into the fourth task, which is assessment as treatment. Pat Denning is a person who coined this phrase. She's another one of the major contributors to this work. You know, that now that we've got a good alliance and relationship, somebody has some capacity to, excuse me, sit still with distress, it becomes possible for us to do a collaborative assessment over time as we work together to clarify the meanings, the functions, the psychobiosocial factors that people are responding to with these behaviors. The fifth task is so key because to the extent that this is embracing ambivalence, to the extent that people are turning to substances for positive functions alongside the part that is troubled and concerned and wants to change, seems to me we need to invite that ambivalence into the room. Very often, these patients are in a constant battle between these two parts of themselves, right? And that battle, you know, the angel and the devil is the way some people talk about it. Interestingly, the devil is the one that wants to use the substance, which suggests that, you know, people have devalued those parts of themselves that are expressed around the substance use, right? But if we can invite that ambivalence into the room and kind of develop a compassionate, empathic dialogue with both of those parts, you know, we might be able to support people in developing more of a constructive dialogue about how to reconcile these two different motives or parts of themselves. So just in a simple example, if someone's using to manage anxiety, and we can help people develop alternative ways of managing their anxiety as kind of a new harm reduction goal, it then may be possible to, or people may be more motivated to cut back or stop. And once we've got these new goals, the final task is really coming up with a personalized plan for working toward those goals, which can include, you know, all of the therapeutic modalities and skills and so on that we all know. Next, please. So I just want to say a little bit there, you know, in each one of those tasks, there are skills and strategies, I think, that that we can learn and we can teach our clients and we can help them incorporate to kind of support their positive change process. I wish that I could had enough time to kind of go through the 7 tasks and really talk about specific techniques in all of them, but I have about 5 minutes left and I want to make sure and leave enough time for real Q&A. But so this first task of setting the stage by creating safety and alliance, a close friend and collaborator, Scott Kellogg, suggested this idea that we're wanting to establish an alliance with what he calls the inner leader. Right, there's an aspect of the person that we want to engage in alliance around the therapeutic process, right? Safran and Moran wrote a wonderful book called Negotiating the Therapeutic Alliance. And I love that idea that, you know, the alliance is continually negotiated and renegotiated. You know, that really fits with the idea of we have a collaborative stance with people. We're constantly checking in. You know, how are we doing together? That's the compassionate, pragmatic part. But they found, after looking at extensive research, that the strength of the alliance is based on an agreement about goals, tasks, and the quality of the bond. You know, that's so self-evident, and yet just consider an addiction treatment system that is asking people to commit to abstinence before they've done all of this complex work that we've been talking about, as a kind of setup for failure right from the beginning. This harm reduction approach says, you know, let's figure out what's motivating people. What are your goals? You know, how can we come up with tasks that really fit, who you are as a unique person. And that's going to really facilitate, the therapeutic alliance. Now, just something to consider, as I alluded to it a little bit, but consider the challenges of creating safety with stigmatized trauma survivors, and who have experienced, negative experiences just because they're people who use drugs. It seems to me one very valuable thing that I have found is to disarm these negative expectations, a negative transference based on these negative experiences, by being very, very transparent about our harm reduction stance. I'm right out there. And what I mean by my harm reduction stance is that I don't make presumptions about the nature of people's struggles with substances, the nature of that relationship. I do not have a presumption about what goals or what approach to change best suits them. I really put that out there right at the outset. And that my job really is to support them, if they wish, to clarify, how they ideally want substances in their lives, and then we can figure out how I can support that process with them. So the transparency, I think, very typically, very frequently turns, quote, unmotivated patients into highly motivated patients when they hear that there's a harm reduction alternative that will truly meet them where they are, invite them into therapy on their own terms, right? And then work collaboratively to figure out, what therapy is going to be most useful to them. I think this multiple meanings perspective, and also, by the way, the stages of change model, I think can be very important to share as an alternative formulation. People are often thinking, why the heck can't I stop? Why the heck do I keep using when I, am so concerned about losing, everything of value in my life? And I think these alternative formulations can really help people make sense, understand, and also map out, the issues that need to be addressed in a therapeutic process, so that this formulation can really lead to or give rise to a treatment plan that both the patient and the therapist can buy into. I have one more slide I want to say a few things about, and then we'll open it up for Q&A. So next, please. So this is how I translate those harm reduction principles into actual skills, sort of operationalize the harm reduction idea of starting where the client is, where the patient is. It begins with an invitation. How can I be helpful to you? It sends the message right from the start that this therapy is a non-presumptive therapy. I'm not going to presume that I'm the one in charge. I'm the one, with preconceptions about what's going to be helpful to you. I invite you to share with me, where are you and what do you want and how can I be helpful? It sends the message, I want you to be in the driver's seat of this therapy. Then we get to listen empathically, and that's, really think about it as harm reduction listening, listening for content, listening for feeling tones, checking in with our own emotional responses as a kind of guide to what may be going on, particularly if people have experienced trauma and they're dissociated from, from parts of themselves. Often, our emotional reactions become the clue or the key to understanding, what's being dissociated. But empathic listening then kind of may lead to a collaborative inquiry. I want to invite that inner leader into alliance around kind of exploring more deeply into what, people are struggling with. And when I really feel like I've got a real clarity about what that person is bringing, what they're wanting, what the struggle is about, then I get to empathically reflect. This is what I think I heard you say. Did I get it right? That's the check-in. And when the person says, yeah, I feel really understood, then I know that we're in alliance. Finally, there's a lot more we could say about this, and maybe if I come back at some point, we can have a whole session on countertransference management. But I think it's such a key, because people that are engaging in really risky behavior are going to kick up all sorts of things in the helper. And some of those feelings of fear, of frustration, of are really a reflection of the person's behavior. Some of them are that kicks off all sorts of powerful things in us about our own unresolved trauma, or other difficult personal experiences that we've had. And so kind of a primary focus on kind of working with our countertransference, working to kind of contain it, to understand it, to have a place to clarify it, right? To figure out how that may inform our understanding of the patient and what's happening in treatment, I think is key. So why don't we stop there and see what questions there are or comments?
Dr. Tatarsky, that was beautiful. Thank you. I could listen to you for another couple of hours. Thank you so much. You're such a wealth of experience and thinking, and just so appreciate everything you're saying. I don't know, Dr. Gerber, if you wanted to start us off with a thought or a question, or.
I would love to, and I'm gonna take advantage of my position here to ask you a question, because there's so many great questions out there. So I promise I will just keep it to one, and then pass it on. Jeff, you and I can go back and pick other questions. So what you're preparing us for, it seems to me, and you've just done such a beautiful job setting the stage for this, is what I like to think of as sort of a post abstinence versus harm reduction world, where we don't see these as somehow a binary choice we have to make, but we're an integrated model of doing what's right for patients and meeting them where they're at. And that just feels to me like such the natural and right place to be. It's funny how sort of the old fights of our ancestors, right, kind of come down with us. And the challenge, maybe even in our students, is to learn from everybody and then move past it. But in order to do that, it strikes me that one question that I sometimes struggle with is, what is it about the abstinence approach that has made it so attractive over the years? And I'll tell you where my mind goes, but I would love your thoughts on this. I think from a sort of basic psychological aspect, for some people at some time, having a hard rule is actually easier to follow than a less hard rule. And I think back to things like, most vegetarians I know don't say, oh, I mostly don't eat meat. They say, I never eat meat. Yeah. And if I want to go to religion, right, in various faiths, people say, I never eat X, not I mostly don't eat X, even though all the arguments, and are good arguments for why historically there were prohibitions, would make more sense from a more gradual. So it makes me think that it's easier for some people in some circumstances to do this. So I would love your thoughts about how do we acknowledge that for some, that hard line is useful, because it also makes me think that sometimes then the notion of harm reduction for those individuals is actually a little frightening, because if I don't have the hard line, am I going to have more trouble controlling my behavior? And love to hear how you address that with either professionals or with patients.
Yeah, wow. That's a huge question. Well, there are a lot of things I could say. First of all, I think it's important to acknowledge that we don't need a disease concept. Well, historically, the disease concept was really promoted mostly by Jelinek, E.M. Jelinek, in the middle part of the 20th century. He did a survey research of a group of AA members. Now, AA is an abstinence-based approach. And obviously, many, many people find AA with its structure and its clarity and its support to be life-saving and wonderful, right? So there are people who gravitate toward that program or toward abstinence-based approaches because of what you're talking about. It's clear. It's not ambiguous. And whatever the psychological benefit of that is, it certainly is very useful for some people. Others recoil against it. It sets off rebellion. It's like being dominated by, my abusive dad, or, all sorts of complicated things. But going back to Jelinek, so AA says it's an abstinence-based program. It has a notion of the disease of addiction, which Jelinek then wrote a book about and supposedly put out a scientific document that was actually completely unscientific. AA is a wonderful fellowship, but it's not a treatment and it's not based on science. But for interesting historical reasons, maybe partly because AA was in the early days the only approach that was really available to most people that were struggling. That community, I think, really became the main influences on our modern day addiction treatment system. So there's history there that I think is one explanation. I think the other explanation is partly because of that old disease model, which says addiction is a permanent, chronic, progressive disease only arrested by complete and total abstinence. And if you don't accept that, you're in denial. And if you don't enforce it, if we don't enforce it, we're enablers. So most of us who are a little older all grew up with that model. We don't want to be enablers, we want to enforce abstinence. But I think also because of that, the complexity of what goes into helping people explore whether moderation is truly an option for them or not, has not really been center stage. I like to think of kind of really simplistic analogies, but if you were a terrible driver, if one were, you got into a bunch of accidents, I'm sure your loved ones would say, stop driving, but if you were a headstrong guy or, needed to drive for your job, you might say, I'm not willing to accept that I have to stop. But you might need a tremendous amount of assessment to figure out, what were the factors that contributed to your being a terrible driver? Skill deficits, personality issues, you get crazy when somebody cuts you off and then you go on a race with them. So there's a lot of assessment that needs to go into this, and then a lot of work on behavior change. And so I think for many people, it is much harder than a commitment to abstinence. And helping people recognize that about themselves. Are you willing to do the work of a deep assessment and, on many levels, to really figure out if a non-abstinence path is right for you? That's a long-winded answer, but some thoughts.
Thank you.
Beautiful. The questions are rolling in faster than I can keep up with them, Andrew. So let me first, though, read from Dr. Murata. What he says is really a reminiscence, because I think it's just such a beautiful idea. Thank you, Rocky, for sending this in. I remember that the impulses of young clinicians in my time to help in any way and not give up on patients had to be suppressed by their supervisors and professors. One was not behaving like a professional, not being sophisticated or knowledgeable enough. Thank you for helping to reverse that process. And following that comes many thank yous from many people in the comments, just to send your way. There are a couple questions about when people are intoxicated and show up at your office for therapy and how you deal with that in this model.
Yeah. Thank you, whoever, for asking that question, because it's the question that always comes up. So if we presume that substance use per se is meaningful, I think we need to presume that somebody showing up in the office is meaningful, intoxicated is meaningful. So this standard practice of presuming that people are not in a condition to be able to benefit and need to, can't have their session, I think misses tremendous opportunities. I want to know, why did you come to the office today intoxicated when you haven't before? That's a tremendously meaningful act that might reflect many, many different things. First of all, trust, that you, maybe it was what we call a transference test, right? You say that, you accept me with my substance use wherever I am. Well, what if I show up intoxicated? I've been thrown out of everybody else's office. Are you going to do the same thing? So it could be a really important moment where the acceptance of that can send a message to the person that can be really transformative. Or let's say, they come in sober all the time, and, you don't really know what terrible shape they can be in, and they can't really communicate it. Or maybe they just had a terrible experience, and the only way they could get to the office was to have a couple of beers. So I don't want to, and maybe they're actually wanting to sabotage the therapy. I don't know, but again, this non-presumptive stance, I think, which invites people to be curious together. Now, then some people say, yeah, but what if they're really wasted, right? Can any meaningful therapy go on there? And, certainly the more wasted or intoxicated a person is, probably the less likely they are to be able to really make sense of, the verbal communications in therapy. But there still may be a very, very powerful relational experience that can go on for somebody that, you took care of me. You made sure that I was safe. You maybe felt scared, but you didn't, react in a way, or maybe you felt frustrated or angry. Now, similarly in groups, because people often ask this, well, can you have people who are in mixed groups, some people pursuing abstinence and some moderation or safer use. And I believe that is a very, very powerful form of group. We call it a mixed goals group. And the reason it's so valuable is that people often in the journey toward clarifying what their ideal healthiest relationship is to a substance tend to go back and forth. They do an abstinence experiment, then maybe they do a moderation experiment. And so everybody is joined around wanting to discover what their ideal goal is, but not necessarily the same goal, right? And you can keep your peer group, your support group, rather than having to kind of leave group if you decide you want to experiment with moderation. And I'll be very quick. But then what about when somebody comes intoxicated? And people often say, aren't the people pursuing abstinence going to get triggered? And, don't we need to protect them? And I would say, maybe. So we could have an abstinence focused group for people that only want to be in a group with people committed to abstinence. But in a mixed goals group, if you get triggered in group, you can then work on what got triggered in group, rather than try to keep it out of group. And then people get triggered on the side, on the street when they're passing a bar. But having different tracks and different options for people, I think the more options we have, the more people we can be helpful to. So we can have a mixed goals group, an abstinence focus group, or even IOPs, that side by side, two tracks in a way.
I'm going to synthesize a few questions. I know we only have a few minutes left, but some of the questions are around applying this model to other settings and populations. And so I'll name three of the ones that came up. One is somebody asked about within the criminal justice system, such as probation programs, particularly given that that's historically more of a kind of top-down authoritative model.
Yeah.
Another was it with teens. And then the third group I wanted to ask about was in settings like a residential hospital where people are abstinent by geography, but we are aware that when they leave this setting, many of them will need to be prepared for a more harm reduction model. And I'm so curious, pick any of those that you want to respond to, but how do we generalize this approach to other settings?
Yeah. Well, in a residential setting, which requires abstinence, and actually, I think the field, we're in a moment in the field in which all of these questions you're asking are at the cutting edge of how do these ideas and these practices get translated into practice. So I would invite everybody on this webinar to contribute to if people wish to, kind of figuring all of this out. This is where we're on the front lines here. But so in a residential setting where you don't want to invite people, if this is the culture of this particular setting, in with substances, I think that can be, if that's your choice, a programmatic choice, that's what's requested or maybe even required. But we can still bring the harm reduction therapy framework into that setting. And I think it's so important, again, to make it explicit, because a significant number of people in the residence are going to be using when they get out. And traditionally, that conversation has been forbidden, so that people have the intention to return to use, but they miss an opportunity in residential treatment to really look at that. What's that about? What are the risks? If I do intend to do it, how? With adolescents, this is very controversial, but most people that work with adolescents know that if you're not having a harm reduction mindset, you're not going to be able to have a meaningful dialogue with your young people. If we don't make it safe for people to talk about their substance use and their motivations and their intentions, then people do it anyway, and they just don't talk about it. And then we have to urine test. Whereas in an environment that says, let's talk about it, even in families, right? Let's talk about it, and create a safe, context for this kind of communication. Then our young people are going to bring us in, and we're going to be able to have meaningful conversations about, how risky, why, what role is this playing in your life? What are the negative consequences, et cetera. And just, in criminal justice, there are a lot of people in criminal justice that are now struggling with this. I actually did a training to a bunch of parole officers, and they were like, this makes so much sense, but we're told we can't do it. And I said, well, why don't you have, we need to have conversations. You need to have conversations, right? About if it makes so much sense, then maybe it's time for some changes. So.
Dr. Tatarsky, we are at the hour. I just want to thank you so very much for joining us. Your wisdom, your compassion, and your brilliance really is just a joy to sit with you. So thank you for being with us. And Dr. Gerber, as always, thank you for joining me today up front with the questions. We will have our last grand rounds next week, and hope that everyone can join us for today. Remember that a CEU, a link to CEUs will pop up in the chat in your browser as soon as we conclude this. When we leave, we break our connection that you've been talking about, Dr. Tatarsky. So it's a little empty. So thank you again for being here, everybody, and till next week.
Thank you. It's a real pleasure to be with
Thank you.
all of you. Yeah.
Bye-bye.
Andrew, thanks everybody.